Good morning. Good morning, everyone. It's the second day two complex PCI 2024. Actually, we're gonna start with main multi-vessel disease live case session from the Asan Medical Center. My co-moderator, Jafary from Singapore, Dr. Ahn, Dr. Dinh, Dr. Do, Dr. Hyeon-Cheol, Gwon, Dr. Hong, Dr. Liao, Dr. Wong. So, come on the stage. Okay, can you hear me from Asan Medical Center? Okay, Dr. Bach.
Okay,
Can you hear me? All right. So good morning.
Welcome to the Complex PCI 2024 and our live case. I'm very happy to share our very excellent and very complex PCI case. And today we prepared a very diverse chip procedure complex PCI case, including left main disease and bifurcation region and the severe calcified region and the lung region. I'm D.W. Park from Asan Medical Center. I'm gonna first introduce our team. And the first assistant is Junghoon Lee. He's a professor in the Eunpyeong, the St. Mary Hospital. And the second assistant is Seung-Jung Ahn, and she is our senior fellow. Okay, let me start the case presentation. Is Dr. Ahn, can you present patient background?
Thank you. It is my privilege to present the opening case. We have a 68-year-old lady presented with persistent chest pain. She'd been treated medically over the past 3 months, but her symptoms didn't improve. Next. She has hypertension and hyperlipidemia on medication. Next. Electrocardiogram show normal sinus rhythm with heart rate of 60 beats per minute. Next. And the chest X-ray show no signs of congestion or pulmonary edema. Next. She has normal LV systolic function, and the CT scan showed moderate stenosis in the distal RCA and the proximal to mid LAD. Next. And this is the initial angiogram. She had right coronary dominance, and there's a moderate stenosis in the distal RCA. And the left coronary artery angiogram showed severe stenosis in the mid-LAD. Next. And there's a mild stenosis in left main bifurcation area with left circumflex otium involvement. And the severe stenosis extends from the proximal LAD to mid-LAD. Next. And this is our plan for today.
So I'm gonna re-show the angiogram. This is the first arteriocoral view, and as you can see, this patient has the right dominant system, and the suck is not small, but relatively small compared to the RCA. We can see some prox suck part. There is some intermediate stenosis, looks like, and also distal main, the disease. And the next. So, and this is the spiral view. You can see, and the distal left main, some haziness, and also suck ostium. There was some narrowing. And the next. So, and this is the arteriocranial view. You can see absolutely distal left main is angiographically and more than 50%. Also, and the disease was diffuse extended from the distal left main to the mid to distal LAD, and there was no tandem region. That looks like diffuse region was extended involving the distal left main and the prox LAD and middle LAD, and the distal LADs looks like a very tight. Also, she has a very the large size of the diagonal branch, but diagonal branch ostium looks okay. And next. Okay, and the previous view, we shows the this patient and the 68 old and unstable angina. Okay.
Okay, before you want to treat, we want to discuss with the panels. You've changed a lot in terms of a concept of a main revascularization, PCI or bypass surgery, right? Jafary, what do you think, as for particular these cases, so dominant RC and diffuse LAD disease remain disease 50%? Is it just still indication for PCI, for indication for bypass surgery?
I think both are reasonable indications. In our practice, we would discuss the option of surgery and consider it, but I think PCI is a reasonable option here. The length of the lesion is long and it's diffuse. I think you will almost certainly have to extend the stent from the LAD into the left main. I think sort of a provisional crossover approach across the circumflex would be reasonable, and I think keeping the side branches like that big diagonal open would be reasonable. Whether or not you need to use atherectomy here or not, I think it would depend on what the imaging will show, so imaging will be key.
Dr. Ahn, what do you think? Just bypass surgery or PCI?
I think it's like when we think about the bypass surgery or the PCI, maybe it's good for us to think about in the region characteristics. I think it's even though it's some left main to mid to distal elevated diffuse long region, it looks like some good candidate for the PCI. So actually, for me, I think it's I'd like to try to the PCI rather than the bypass surgery.
Great. Dr. Gwon,
Maybe you don't like my opinion. If this patient were my patient, I observe this patient with careful medication. Because there are a lot of disease, diffuse disease, moderate stenosis, a lot of bifurcation. Maybe we'll have a more complication than the benefit. Or another approach is that the FFR. Use FFR, it must be significant. And we are carefully observe the step up. A step up point, a major step up, we can treat with possibly DCB or possibly stent, and observed patients. I believe that that approach is very similar to bypass surgery or even PCI in terms of a MACE. You don't like that, right?
Oh, Dr. Do, Dr. Do, what do you think?
Okay, I think it's probably a PCI case, but at first we must check iris and FFR first and decide which part should be treated. But the one thing must mention is the most severe part of the LAD is located at tortuous part. Sometimes there is a muscle breach there, and if you use a very big stent or higher pressure, sometimes rupture happen. And currently we are trying to combine iris and QFR together. After check iris, it will give you the value, something like FFR will help you decide very quickly.
Anyway, so not a simple, selection. Dr. Hong, Dr. Liao.
Okay, Dr. Liao from Taiwan. In my opinion, this is PCI cases, but the one issue is which part is the critical point. It looks like a long lesion and the distal limit, but according to other commentator opinion, I think the IVUS intravascular imaging and the FFR is the should be integrated, and to decide it which is the which one should we to do the intervention, the critical point, or long standing or spot standing. It's the PCI issue.
아까 그랬냐?
Dr. Wong is here. Wong.
Yes. I think this patient is presented with unstable angina, so revascularization should be indicated. Whether it's CABG or PCI, it depends really on patient's wish. We have to make a shared decision with patients, discuss the pros and cons. But definitely, the PCI can be done in this case. And if I do PCI for this case, first I will evaluate the left main bifurcation with imaging to see whether upfront 2 stents at the left main bifurcation is needed. For diagonal, I'm not worried about that. I think it's okay to just go for provisional stenting. So most likely it end up with 2 stents, one from a mid to distal LAD, another one left main into proximal LAD, and then whether we need, just as I mentioned, whether we need upfront 2 stent at the left main bifurcation, that depends on imaging.
Dr. Buck, did you hear that you changed a lot anyway during the lesson,
Yes,
right?
yes, absolutely.
PCI
Yeah,
candidate,
yeah.
and so you have to explain the Fahim main trial and which one randomized something like that.
Yeah, I think the merit of a complex PCI conference, and this is think about your case, and depending on your dynamic thinking, I can change my mind. Absolutely, as shown, that is a panel discussion, and the treatment strategy is very diverse and very dynamic according to the treating physician. So I think this is a case very many points to discuss, and this patient is, as shown, cranial view, and you can see distal limb main and the involving the distal part of LAD. So, and we are now actively conducting the Fahim main trial. Fahim main trial is for angiographic diameter stenosis more than 50%, and we are randomization, one arm is FFR group versus angiographic guided PCI group, and both group, and based on the recommended guideline, the final optimization and the intravascular imaging can be used in the both group. So, and this patient was randomized to the FFR guided arm. We already check FFR as well as imaging every vessel. So, and it's such like a very diffuse region. We cannot separate the region in the no tandem region. We usually check it up the FFR from to the distal LAD. So FFR was less than 0.8. We just treat, and then finally do is a post PCI FFR. So we already check it up the FFR. Can you show FFR?
Great. Would you show us 0.65?
Yes.
65.
It shows FFR Y. Okay, yeah. So, and this is our typical example of the FFR for the distal main to the LAD. If tandem region absolutely present, we treat the distal part, and then we check the left main FFR. So depending on FFR was more than 0.8, we just defer for left main region. So FFR evaluation, very diverse clinical scenario, intermediate region, multivessel region, STEMI, non-STEMI, at AMI, deferred revascularization, complete revascularization, evaluated everything, but just remain the spot point is a left main disease. So we already enrolled more than 100 patients. Our target is 940. That would be one of the landmark trial is for evaluating the role of the FFR in left main disease. So 0.65. So, and absolutely, we should decide to PCI or bypass surgery revascularization. And even this patient was for last 2 years was active medication, including aspirin and the hydrostatin and the Herban and the Sigma and there are many beta blocker. At least 6 medication was given. Although the patient is complaining the unstable angina, absolutely the most of audience panel is fully agree we should do something and beyond the optimal medical therapy. Also, we evaluated IVUS, and the next one.
Did you check a circumflex FFR those?
We didn't check the circumflex in the previous view, and the SOC is relatively small usually, and we checked the FFR was positive, but that was absolutely we treat the PCI, and in the involving the two vessels, if you check the FFR, LAD, and suck, in almost all cases, FFR from the LAD part is much significant reduced. So, and considering this patient was the diminutive or suck, and we didn't check the FFR. So next one.
So, Dr.
So-
Park, did you check
Yes.
the pullback?
Absolutely,
PCI pullback?
absolutely.
Where was the
Yeah.
major step up?
Yeah, major step up from the distal part is 0.65, and the middle part, just the cross over the distal tight LED stenosis is 0.82, and the left main, the prox part is 0.98. So, and the major step up was shown in the distal LED part.
In that case, so which strategy do you prefer? Just treat the LED and leave the left main because the FFR is not significant?
Yeah,
after
so
treating
in
the LED, or
our-
treating the older lesion?
Yeah, our main trial, if you separate the tandem region, there is a normal zone, absolutely, and we do treat the distal part and then reevaluation FFR. But this patient was a full segment involving distal LAD and mid LAD, as well as prox LAD and distal and main, and we did not separate at all, and then just the one-time FFR.
I think if you look at that LAD, the mid LAD is about the same size as the distal. So you clearly know even before IVUS that there's diffuse disease. And I think the problem with bringing up spot stenting is that you will end your stent in a lot of plaque. And the longevity of the procedure goes away. The patient will come back sooner or later with more events.
Absolutely,
That's the
absolutely.
issue. Yeah.
So
Yeah,
what
yeah,
would you
Jafary,
do
yeah.
that, Dr.
So
Park?
next
Would you
one.
show
So,
us
and,
obvious findings?
Yeah, okay, next one. So in next one, the IVUS does not pass, and the distal part is a very narrow part, and we did 2.5 the compliant balloon, the pre-dilation for evaluating the IVUS. And next one. Okay, we did the 2.5 compliant balloon. Next one, and next one.
2.5.
Next one. Next one. This is 2.5, and this is after pre-dilation. So at this moment, we check the IVUS. Could you show us the IVUS from the distal part to the distal and main? So, and this is the distal part of the LAD. There is some dissection, and the vessel size is looks like 2.5. It's a very tight stenosis even after pre-dilation. Here is a vessel size is 3.0. You can see the spiral dissection in the distal LAD part. Okay. And,
Diffuse disease, and we
absolutely.
2.5.
Yes, this is prox middle. You can see the dissection was the involving. There is no normal zone. There is no tandem region zone. The plaque absolutely extended the whole segment, distal and main,
Where is it?
to the yes.
Prox LAD here?
Here is prox LAD. Even prox LAD, there is some severe calcium and the plaque. Here you can see some dissection. Here is a vessel size is a 4.0. Is plaque was totally extended. The suck is coming from the 7 o'clock, and this is a distal main,
Great.
and the distal main plaque burden seems like 50 and 60%. Also, we checked the suck to the left main. Could you show us suck? angio를 suck. Okay, angio suck를 바꾸고. Okay, first view. We got it. And then the play. So, and this is another issue, and the suck part is vessel size is 3.0.
Big vessel,
And
right?
this is, yeah,
Rather
this
than
is
distal,
the
3.0
very
or something.
tight prox, yes, prox suck. Here is the plaque
This
burden.
is-
It's the absolutely lumen area smaller than 1.0, 1.5. And also you can see the suck ostium coming here. And the suck ostium is also very compromised, severe narrowing. So we check FFR. FFR was absolutely 0.65 is absolutely candidate for the PCI. And we also evaluation IVUS, and we should the total segment treated from distal and main to the distal LAD. Another discussion part is SUC is 3.0 vessel, but relatively small compared to the RCA. How gonna treat the SUC, Austin? Just leave it alone, or any 2-stent, or any DCB? That would be some dynamic thinking. Any thought from the panel? How do you treat the SUC?
Any suggestion from in terms of real, Okay.
Yes.
Practice.
Dr. Park, this is Huy from Vietnam. Yeah. So I think that
Hey, how are you?
yeah. So left main LED is a very, very long lesions. So and then I can see from IVUS that's maybe beyond the diagonal, the vessel size is just only 2.5. So any idea of doing the hybrid PCI for left main LED, just DCB for the after the mid part of LED, and then stent from proximal to left main. Regarding the left circumflex, I think this is not a dominant circ, so can leave it alone, or DCB can be an idea, but I think if I were the operator, then just leave a Y there, and then let's see after we stent the left main LED and then reassess the left circumflex.
Yes, you proposed the hybrid approach in the proximal big size part is we're going to put the drug-eluting stent, and the distal small vessel part is just a DCB. So frankly speaking, I saw the audience and the panel remember the last TCT Antonio Colombo live case, very similar, very diffuse region involving distal left main to the prox LAD and the distal LAD. Frankly speaking, I'm not satisfied. I'm not, that the strategy is not my strategy. In the Antonio Colombo tried to the DCB in the several times, but DCB caused a very severe dissection. As shown in our result, we did the pre-dilation using 2.5. There was a severe dissection. We cannot control with the balloon angioplasty alone, and we achieved the best result after stenting. That was our strategy. It's just a small vessel, very diffuse distal part. We frequently use the DCB. Right. So frankly speaking, this patient is a relatively diminutive stop. And after stenting crossover to the LAD to left main, for SUC austere part, I can apply the DCB. And then final casing. That was current my strategy. Depending on your thought, okay, I can change my strategy.
Dr. Fahim Jafary from Singapore. In our practice, at least in my practice, that circumflex, I would dilate it, I would DCB it, and then use a gel balloon and keep it open. And try to avoid putting in a stent there. She's 68, she's got a long way to go. And I think putting a complex intervention at the left main circ, I try to avoid that in her.
Great. In terms of diffuse LAD lesions, you're going to do the long stent, right? Rather than any DS component. The meaning is actual vessel diameter is more than 2.5 from the ischemic definition is actually still, I believe the DS would be better than any.
So Duk-Woo from Youngkeun. So actually,
yes.
I think it's when we find out from the IVUS, probably some heavily calcified burden in the diffuse LAD regions. So do you want to make some region modification by something?
Yes, usually at the balloon not dilated well, we apply the additional scoring balloon and cutting balloon, and this patient is a vessel is dilated well. Even the compliant balloon, I think just stent crossover would be okay.
All right.
So on the basis of IVUS, we decided to two long stenting, and I select the synergy stent, and the distal part is based on IVUS, and 2.75 38, and then proximal part is at 3.75 38. So. And on the basis of renovated complex and many trial, including Octopus trial, and absolutely on the basis of compelling evidence in the recent trial, such complex region, left main, diffuse, bifurcation region, this patient is having all components, absolutely indication for the imaging guided PCI, and then test.
So,
okay, got it. 테스트 한 번 더. 오케이. 뒤에까지 한번 찍어보자. 엔조 레디. 그지? 저기 아래까지 레셉터를 지나서. 요거 하나 올리고. Okay. 자, 들어갈게요. This is inflated well. Okay, test. 자, one more test. Okay, inflate. Go. Inflate. 2.75. 10. Just 10.
2.75, 38.
Yes. Okay. Deplete.
Right. We just protection wire for the diagonal branches. Actually,
Yes,
there is no
absolutely.
too much significant disease, and so
10, 12, 14.
we don't, too much worry about that one. So, okay.
Okay. Deplete.
2.75.
우리가 그냥 아이부스로 된 건 얼마 나왔지? 38? 네. 38 안 나올 것 같은데.
So you're gonna do another stand for the
Okay,
stand
test.
crossover to left main,
Yeah,
right?
absolutely. 이거보다 짧아도 되겠다. 32? 3.5? Okay, 아프시죠? And then the stand optimization from the distal AD, the prox left main part, and then we decided to how we're gonna treat the suck as well as final step.
Are you going to post-dilate the distal stent first and then pull the diagonal wire out, or?
Yeah, usually okay. Even the long stand overlap, the usually pull back, it doesn't matter. Okay, 자
Good.
이게 33.5
Touch them. Floor.
boost,
Position.
just overlap.
Good.
Okay, test. 그렇지? 조금 더 들어갈게.
I think it's
Okay,
perfect.
test.
All right.
Okay, go.
Perfect.
11.
It's 35.
Okay,
Size
아파요. Okay, deplete. This is 3.75. 우리 진통제 좀 드리세요. The she complains some chest pain. And then the high pressure balloon we're gonna apply. So I think a contemporary state of art PCI, this patient is absolutely the representative case, and we are the freely use physiology and the imaging guide the PCI. Also, we combination use of the DES as well as the TCB, and we do some very dynamic thinking.
Professor Park, would you like to remove the diagonal wire first?
Yes, and after the distal part, high pressure dilation, and then I will remove the diagonal part.
So I don't know, maybe
이게
I'll
얼마지?
ask the panel, how many folks would jail a wire behind two stents? I always worry about it, although most of the time we get away with it.
Okay, go. 6.
Yes, I think in this case,
Usually,
leave it
side
here
branch
is
wire
okay.
can come out.
Yeah.
The only situation is
Okay, go.
the
10.
diffuse calcified lesion with long stem
14.
treated with high pressure ballooning. In that case, it's very difficult to retrieve, but
자,
usually
10,
it
12.
come out.
NC balloon. 275.
Okay, deplete 2.75. Okay, 20.
High pressure.
Okay.
I think for the audience, it's important to note that
3.75을 할까?
they're using pressures of
3.75?
20 and
Okay.
above. That's the kind of
And
pressure you
then
need
check it
to
up, the
use when you
diagonal.
post-dilate stents.
Actually, in the European Bifiction Club, they strongly recommend part technique, proximal optimization. That means that you need a larger
Perfect.
balloon at the
Perfect.
proximal
I love
part of
it
the
too.
carina.
Wire is very smoothly, we can remove it.
Yeah, it isn't a problem in the most of cases, but
Yeah, absolutely. Some
the
severe calcified region sometimes
the
could matter.
suggestion I'm making now is that you should use the larger balloon just above the large side branch, because the vessel size changes just proximal to the large side branch. So you should you use undersizing a little bit the optimal size for this vessel, then pull out, use the higher pressure over larger vessel at the point of the carina, just proximal of the carina. That's the,
Yeah, that is good suggestion.
the idea of
This is
POT.
375. Okay, got it. Test.
375. NC.
Yes. Okay, here. Okay, test. Okay, go. 6, 8. 7. Okay, deplete.
Yeah. But
3.75 NC. Okay, go. 10, 12, 14. 어머니 조금 아파요. Okay, deplete.
I think
expanded
stent
well,
just
and
the
this is
distal to
synergy
the
stent.
diagonal is a
10, 12,
little bit
14.
oversized. Sometimes the
16.
thing makes the occlusion of the side branch. This is why what I'm saying, that distal optimization, proximal optimization is important to protect the side branch.
Go. 20.
Again, for the audience, I mean, you know, Dr. Park is doing this effortlessly,
Okay,
but
deplete.
you have to be very careful about the guide not hitting the left main stent, and he's making
lateral.
very sure that the guide stays behind the left main stent so that you don't cause longitudinal deformation.
Yes. So at this stage, I'm gonna check it up the angel.
Picture first, right? Great.
Okay, angel ready? Shot. Good.
Perfect.
Nice.
Perfect. Perfect.
And also I'm gonna check it up the here. 자. Shot. Good.
So what size balloon did you use for the left main?
Yeah. So and we use a 3.75.
The left main is probably bigger, right?
Yeah. And we're gonna check it up IBUS. So I think on the basis of angiographic result is perfect.
Yeah.
And the suck looks like a perfect. And somebody wants
Yes.
to DB touch.
What,
I'm gonna
what,
do.
what about the circumflex artery? You gonna do the balloon and DB something? Just
Yeah,
the DB alone is
Yeah, I
another
think
choice.
leave it alone is good option.
Right, I would
and
leave
then
it alone.
I would
somebody
leave it
ask
alone.
FFR, I can do. Is that I'm guarantee 100% FFR negative for such diminutive
You,
stuff.
Dr.
you
Park,
don't need an FFR for that.
Actually, this view is not good for assessment of a circumflex ostium. This is overlapped. So we need to check the
So we're gonna
spider view.
check spider view, etc., etc. Anyway,
It must be okay.
no,
We need to
I don't want to touch too.
Yeah, but even if the circ is,
Okay, here.
Perfect.
even if it's abnormal, single vessel disease, patient can survive without it.
If there are some disease over there, I think it's okay.
Okay.
For the
I agree.
you know,
자, 에피크레니아.
long-term cancer.
진통제 몇 번 들어갔어요? 한 번만 더 드리세요. 우리 어머니 아프신가 봐. Okay, I'm gonna check it
Why
up the
chest pain is
IBUS.
so severe, Dr. Park?
It's very severe. You know, during the procedure,
Fine.
every time patient can complain, chest pain. Yeah. Okay, go. There is no perforation at all.
Maybe because of the
bigger,
oversizing
2.5.
at some point.
Yeah. So, and this is the distal part of the LAD.
Nice landing zone.
I think initial vessel 275, and I think it's dilated well.
Great expansion. So
Yeah,
stent area is
yeah.
at least more than 5-6 millimeter scale.
Yeah.
The diameter is
There is
2.5.
some eccentric,
Perfect.
but the lumen area is okay.
It's a small, but still. Quiet enough
good.
stent area. That is most important part. Right? Diameter is 3.0, all right?
Yes.
Almost 7, 8.
This is a proximity part, and the fully dilated well.
Stent expansion is good.
Yes, excellent. I think it's at 6 o'clock.
Even
The
the
suck is
calcified
coming.
regions. Great.
Okay, this is a distal main. It's just one
Little
part
malposition there.
malposition. I think that would be okay.
1 or 2 segment malposition is
Yes,
covered.
yeah.
I think it's not
Yeah.
No problem for that.
So, okay,
You
and the
wouldn't
previous
dilate
view.
this a little bit more?
Sometimes we don't need that.
Yeah.
Big vessel.
previous view.
Segment malposition is not.
So at this moment, I'd like ask the panel opinion. You gonna do something more, or just finish the procedure, and we just take 20 seconds.
I'd like to
20
mention
minutes?
that the stenting according to the vessel size is important. This is a concept of POT. In this
Yes.
case, left main looks great, but the LED ostium is oversized. Then left main is a little bit undersized because you use the same balloon size for the LED, ostium, and left main. Some part is oversized, some part is undersized, but it doesn't make any difference in the
Yes,
long-term
yes.
outcome, I believe so.
Yes.
But I like to say that the
Okay, you
patient
compare then
complain
the,
of chest
you know,
pain because of the oversized stent in some point.
Anyway, final result related to the clinical outcome is just stent area, so whatever size it would be, and so proximity main is quite enough stent area. Okay, Dr. Bach, we want to move second lab. It's really good
Okay.
cases, good live
Okay, thank you.
demonstrations.
Thank
you
you.
for that.
Thank you.
Jung-Min Ahn, can you hear me?
파이널하게
Can hear you. Can you hear me?
끝내면 되겠다.
All right, can you hear me?
Yes, I can hear you. Good morning,
Okay.
Dr. Bach and good morning, Fahim. So we prepared the second live demonstration case. So I'd like to introduce our team. So this is Hanbi Park from the Gangneung Asan Medical Center. So the next is Han-Soo Park, is our senior fellow. The Han-Soo Park will present to the patient a brief history.
Okay, thank you. I'll introduce this case. This case is 73 years old male, and chief complaint was default chest pain. He underwent permanent pacemaker implantation for complete AV block about 2 years ago. Next. He had hypertension and hyperlipidemia, and his clinical presentation is stable angina. Next. ECG showed sinus rhythm with ventricular pacing. Next. And chest X-ray showed no significant finding. Next. Echocardiography showed normal LV systolic function and no regional wall motion abnormality. And in CT scan, severe stenosis at distal left main was noted. Next. In coronary angiography, there were no significant stenotic lesion at right coronary artery. But in caudal view, we can see the distal left main disease and circumflex ostial disease. Next. In cranial view, we can see the severe stenosis at the distal left main, and in spider view, we can see the tight stenosis of the ostium of left circumflex artery. Next. The target lesion is distal left main bifurcation, and we plan the IVUS guidance PCI.
Must be very much calcification.
Thank you, Dr. Bach. So do you have any comment and
All right, very tough
recommendation
bifurcation,
from the
right?
panelists or chairpersons?
So, any another simple suggestion for that?
Yeah, this is complicated. This is heavily calcified in the distal left main. I think that ostial circumflex looks calcific. So my strategy would be to wire and then image if I can. I'm not sure if the imaging catheter will cross, and it's quite possible you may have to use atherectomy of some sort to deal with this. And I would be leaning towards a two-stent strategy in this.
Okay. Did you any other suggestion? This is very tough one, and so I really worry about really wire would do pass some circumflex region something. Okay.
I think it is most those complex type of left main bifurcation calcified.
So Dr. Ahn,
Yes.
this is another Fahim main cases too.
Yeah, Fahim main
All
case
right.
assigned to the angio-guided
Angel
PCI
guided.
group.
You don't
So-
care about the FFR, right?
Yeah.
Very. So how would you do that?
Yes, I'd like to introduce the coronary angiogram. In the caudal view, very tight stenosis of circumflex ostium.
Sure.
But the left main looks fine, but change to the cranial view. This is spider view. Cranial view, this left main is very tight. So definitely this is left main bifurcation. So for the very tight stenosis of circumflex ostium, so we prefer in this case upfront two-stent technique. Though we are very familiar with crush technique, so we'd like to do crush technique to treat this left main bifurcation.
Right, great. So would you pass the wires? Is it really?
Yeah, next please. So Dr. Bach successfully passed the wire to the circumflex and LAD, and we evaluated IVUS first from the LAD run.
You worry about that, circumflex osteopathy. Is it easy to pass? Okay.
Just
Anyway.
one time he passes through the wire to the circumflex.
Anyway, LED,
So this is the LED I was findings that this is the distal to the high diagonal branch. The vessel size is 3.5, or lumen is around 3.0. So superficial calcification, but the the big diagonal branch is coming. And here is over.
오디오 봐주세요. 오디오 이상하게 지금 오고 있어요.
Okay. Prox, still prox LED. Eccentric plaque, size-wise almost 4.354. Circumflex coming in from the 9 o'clock.
All the calcium is there.
Yeah.
Right.
Yeah, right.
Not beyond,
is
the,
this
not
left
beyond
main.
it. Yeah.
Left main is almost 4.0 vessel.
All right.
Here is a proximal left main.
Great. Main sharp to
So it
proximal.
looks like nodular calcium in the distal left main,
Yeah.
isn't it?
Stent expansion in
yeah,
this left main is very challenging.
Okay, so circumflex though?
Next, please. So we insert wire, and next
Right.
we balloon the two
Right.
5 upline the balloon, and then we evaluate the circumflex ostium. Could you show us I was finding?
Yes. Please.
This is circumflex.
Big vessel though.
Yeah, circumflex is also the more than 3.0. But the lumen is less than 3.0, so we have to compromise to select the stent size between the around the 3.25 and 3.0.
So far so good. Eccentric calcium.
Yeah.
So however, lumen would be good.
Here is very proximal circumflex, very narrow.
Narrow disease. However, not too much calcium rather than
Yeah.
we expected. Main calcium would be related with the distal main and proximity something.
Okay.
Good.
So the combined with angiogram, and I was finding show that the definitely very tight to severe distal main bifurcation, true bifurcation lesion. So we perform we are doing the crush technique. So after insert the wire and free balloon, we implanted for the circumflex stent using the 325 18 millimeter giant stent. And then next, this is very important to protrude a little bit more the stent balloon and inflated the high pressure up to the 20 atmosphere. And next, so this is a 4.0 high pressure balloon. We crush the circumflex stent. And next,
Balloon crushing, right? First.
yeah.
Balloon crush first. 4.0.
Okay, this is after the circumflex stent implantation and after the balloon crushing to the circumflex.
We don't need a stent for that.
Yeah, balloon angioplasty result for left main looks very fine, but you can see that there is some the dissection, major dissection. We apply the 4.0 high pressure balloon. The left main is more than 4.0, but
Jung-Min, this Fahim from Singapore, given the volume of that calcific nodule in the main, did you consider volume reduction with atherectomy? Was that something that was on your mind?
Right. Dr. Ahn, you can answer, right?
yeah. So atherectomy previously, the very old story, the very first left main stent report is atherectomy plus the IVUS in the left main stenting. SA Bach published that data. But unfortunately, at those days, atherectomy did not reduce the instant restenosis rate during the embryonic follow-up. So, yeah, it could be a good option. But if the balloon cannot passing through, the balloon cannot delay the calcify the left main disease, then I think definitely we need the atherectomy. But to reduce the plaque volume, I don't think it is effective or not.
All right. In the
Do you have any comment?
in the year of bare metal stent, Jafary, and actually debulking, mass debulking may be helpful to reduce the intima hyperplasia or something like. However, in in the of a drug tungsten. Anyway, drug can, inhibit something like that. Another issue is that this, as you say, lots of calcium over there, right? In suckling. And so, what do you think is rotor ablation pre-modification with the rotor ablation and just NC balloon? How would you do
my concern would just be that would you get full expansion? It looks like the balloon, the 4O balloon expanded very well. The problem is, of course, you don't know until you use the balloon, and once you use the balloon, then it becomes difficult to do atherectomy. So I have a lower threshold to just, atherectomize when I see such heavy calcium. Love to know what the panel thinks.
So actually, I think this patient is not so high plaque calcification burden, but if we have some more, probably we need some region modification using the rotor ablation or some scoring or cutting balloon, because the reason why that in the upfront two-stent technique, probably if we have a very heavily calcified plaque burden, is in the future is the high instance of MACE. So I think it's a two-stent technique, region modification, even though it's a drug-related stent error, right. I think it's important.
So, Dr.
We fully agree with your opinions there. So before stent implantation, region modification is definitely very important. But fortunately, we applied the 4 high-pressure balloon, but there is some dissection. It's kind of a therapeutic dissection. It may help facilitate the further the expand of the left main stent. In addition, the patient is very stable. I think this is the beauty of crush technique. During the crush technique, it looks like a complex. The step is a little bit complex, but during the procedure, patient is very stable because every side branch flow is not compromised during the procedure. So after balloon crush, I'd like to implant the main stent. Yeah. So based on the IVUS findings, edited stent length is 33. The distal landing is below the diagonal branch, and to the left main ostium.
Size-wise?
This is 3 to 5.
3 to 5.
Test.
Dr. Ahn, this is not DK crush, right?
Perfect.
Yeah, not DK crush.
What do you think about DK crush? What didn't you use the DK crush for this lesion?
DK crush is a very good test, please. Okay, yeah, it's very good. In play. DK crush is very important. Then why the Hyeon-Cheol made the DK crush? Because after depilation, after the classical crush technique, many operators failed to do the final kissing balloon dilatation. As you know that for two-stent technique, final kissing balloon is very important to reduce the risk of stent thrombosis depletion. But nowadays, stent strategy is very thin, so we are very familiar with the crush technique. So in our centers, we never fail to the rewiring and balloon delivery to the circumflex. So to spend the time and spend balloon, we prefer just the crush rather than decay crush. But if there is a very calcified circumflex ostium and stent of the circumflex ostium is less expanded, then decay crush would be a good method to facilitate the rewiring and the balloon delivery. Ready?
So, take a picture.
Yeah. Okay.
It's great.
So, yeah, at this moment, I forgot, I don't care the circumflex because there is a stent and ready.
Perfect, perfect.
So, this moment, it's a time for the LED optimization. Before rewire, the LED optimization is more important.
What size balloon?
So after IVUS evaluation. So definitely we need 4 high pressure balloon.
4 high pressure?
Yeah. But after
Big
IVUS
balloon,
evaluation.
kind of a pot technique, right?
Right. But before balloon angioplasty, I need the IVUS first. Run, please.
Is it
Left
ready?
main, yeah, this is LAD, huge, but the
Distal
distal,
325.
there is some size discrepancy.
Yeah, distal landing is good. Still relatively smaller than the vessel size. However, perfect position. 325, you mean, right?
Yeah. For LAD, I'd like to apply the 3 to 5 high pressure balloon.
Great.
We can use it to the circumflex ostium. Complex also the 3 to 5. And for left main, this is almost left main. The 4O, definitely we need the 4O.
Yes, more than 4.
Yeah. This is circumflex coming from the 7 o'clock. This is left main. Relatively well expanded. Definitely we need the high pressure.
Good expansions, right? So we need
Yeah.
a high pressure for that.
Yeah.
Dr. Ahn, so this is Huy from Vietnam. So just curious, if you stand until the ostium of left main, so you mainly based on the angle to choose the landing zone of proximal stand, or do you use any dedicated technique to make sure that you cover the ostium of left main?
So depend on the situation. If there is the osteal disease, definitely I need to cover the ostium. Then, yes, 3 to 5 and 4. So the if there is some disease, then I try to protrude a little bit to the aorta. But there is no disease of the left main ostium. I try to just precise stenting for the left main ostium, but there is no rule. So the multiple projection is necessary, and plus some experience is necessary.
Okay.
This is just 35.
Anyway, at the beginning, we worry about heavy calcium for circumflex ostium main branch. Those. So, all right.
This is
Jafary, I gotta, there are calcific lesions, right?
Right.
So just we discussed about that. NC balloon can work. I don't believe, I don't know, any data, actually the rotoblation and the other atherectomy debulking would be better than just the NC balloon. Do you have any?
I don't think we know. I don't think there's good enough data, but what we do see is that when there's nodular calcium, you often get some eccentric expansion, and sometimes that can create challenges. So my point basically was that once you dilate, you lose the option of any atherectomy, when you create a big dissection. So if you're going to do an atherectomy, you do it up front. But I mean, I fully agree. The stent looks like there's a very good stent area in the distal left main. Even if it's eccentric, the area is good.
I think the problem is the birth to artery ratio. For the sufficient stent expansion, birth to artery ratio is around 0.5, at least 0.4. For the left main, it's impossible to achieve that with the rotablation.
14. This is for high pressure balloon. 16. Deflation.
Great.
20. 24. Deflation. So the cranial view, before stenting, there is a very tight distal left main stenosis, calcified. 20, 24. But after stenting, there is no indentation in the high pressure balloon. So I believe that the stent expansion should be good.
Yes, very well expanded.
Yeah. For 28. So usually we are preferred the jockeying guiding catheter during the left main.
You apply the 28 atmosphere, right?
Yeah, right.
28.
Yes, 28.
So final balloon diameter is what was it?
What is the final balloon diameters? 4.26. 4.26.
4.3, 4.2.
Yeah.
Right. Big enough, right?
Very good, yeah.
So, ready? Okay. I finished the LAD side stand optimization, and then I'd like to insert the wire to circumflex.
So, Jung-Min, let me ask you a question. When you rewire the circumflex from distal strut or proximal strut, or doesn't care about that?
I don't care actually. Ready?
Previously, Dr. Chen published a paper that proximal to mid location wiring is better than the distal location of the wiring.
Almost perfect.
In most of cases, it does not happen that way.
Yeah, I think so. So this is very interesting. That after the crossover, the European doctors favored the distal wiring, but the two-cent technique, DK Grossi, so Shaolin Chen group favored the proximal wiring. So, but even though I think once the wire passing through the circumflex, I'm very happy. I'm very happy. This is the used one. Someone asked me to use the special wire, but usually I don't use the special wire.
We have done some bench testing. If you wire from proximal strut, and you make a mental carina protruding into the main vessel. So I prefer to a little bit distal to wire.
Takes time.
Actually, to distal wiring in the cross technique, you will remove the stent from the carina, expose the carina out of the stent. So that's why we prefer the proximal stenting.
So don't too distal. Just from middle, a little bit distal, it's fine.
Yes.
Yeah, most of the time, you just take what you get.
Perfect.
Yeah, nice.
2.5. 2.5. Use the balloon 2.5. Combine the balloon.
Compliant one, right?
Okay.
All right, easy to pass.
One thing, Dr. Park, I noticed is that when the stent was deployed, the dilation was done distal to proximal. I think with the Junghoon's guide, you're actually quite safe. But if you're using a supportive guide like an XB, it's sometimes better to dilate the left main and make sure it's expanded so that the guide doesn't distort the stent. So I think, if you're not using Junghoon's guides, probably dilating the proximal left main stent first is a reasonable thing to do, because you can get stent deformation with the guide otherwise. Junghoon's guide is a lot more controllable, so it's a different story.
Yeah, deflation. So that's why we prefer the Junghoon guiding catheter rather than.
Perfect. You've seen, it's really,
This is 8 French,
kind of a good
right?
technique,
deflation.
just push in very proximal part, inflation for that, and push in.
Is this the 8 French?
Yes, 8 French guiding catheter, yeah, right.
So with 8 French Junghoons, you get a fair amount of support and it's a lot more controllable. But 6 French Junghoons would be very hard to do a case like
3 to 5.
Are going to do kissing balloon?
Yes, final kissing balloon. Circumflex 3 to 5, because we know the circumflex osteum vessel size. In addition, LAD side is 4O.
4. Great.
So we can do the 6. We can use the 6 French, 7 French, but for left main, final balloon size would be the more than 3O and 4O. Use the high pressure balloon. Very difficult to passing through the 7 or 6. So I prefer the 8 French guiding catheter. Please give me the new one, please.
Ready
for all high pressure balloon.
And the anchoring doors.
For high pressure balloon, please.
So this is also a good example. Used balloons will have a hard time crossing the side branch. Don't force it, just take a new balloon. These are not the cases where you want to save on balloons.
Dr. Jafary, do you think the XP curve can make a difference crossing the balloon in this case? I don't know.
I think you get more support for sure.
Right.
But then the issue is you have a higher risk of stent deformation.
In our cath lab, we don't use a Junghoon curve in any case.
Yeah, same for us, yeah. But we don't use 8 French guides. I mean, the most we'll do is 7 French. And we do everything radially, so you can't do 8 French to the radial.
Yes, I fully agree with your opinion. So some operators always sometimes asked me, why do you use Junghoon, why do you use 8 French? But if I believe that the operator can manipulate the guiding catheter more. Sometimes we need a strong backup, like CTO intervention, very calcified long lesion. And in such cases, we can use the strong backup guiding catheter. But the left main is, I think, the different story. Left main, we did not use, usually the high backup is not necessary. In addition, to avoid the stent deformity, particularly left main ostium, the more manipulable guiding catheter would be better than the strong backup guiding catheter. In addition, if the coaxiality is not always good for the XB or EBU. LAD.
Anchoring.
4.
3.5. Okay. Anchoring, right? And push in you use circumflex is used balloon, right?
I'm sorry, it is a new one. This is a live demonstration. Circumflex 10. If the usual practice 10, 12, 13, 14, 16.
I think it's okay to take new balloons for these kind of complicated cases. It's okay.
16, 18, 20,
Pressure.
Very nice.
Consecutive.
24.
Circumflex force and ready.
Deflation. So this is just a sequential high pressure balloon to obtain the sufficient lumen stent area. LAD 18. 18.
So the LAD is a 4O balloon?
4O balloon.
Yeah. It's okay, right? No problem.
So final kissing. 10, 10.
3.1.
Great.
3, 2, 1. So 10, 10.
2, 4, 6, 8, 10.
Perfect.
1, 2, 3. Okay, almost done.
Okay, Dr. you're gonna do IBUS though?
Yeah,
IBUS?
after checking coronary angiogram.
All right, angiogram first, and then okay. Main.
Ready?
I like it. Perfect results, right? So you're gonna do IBUS, Dr. Ahn, right?
Yeah,
And
right,
so
right.
would you, in the later, would you show us the minimal stent area, circumflex area, main dose, right? You made a new cut-up value, but
Yeah.
stent area. You're gonna move Severance Hospital, and they will be back soon, right?
Thank you.
Okay, Dr. Severance Hospital, Dr. Myeong-Ki Hong, can you hear me? Good morning, Dr. Hong.
Good morning.
Can you hear me?
Yes, of course.
Great. It's really, thank you for joining us. And so, you are the third case about a main and multi-vessel PCI, right? Would you start that one?
Okay, it is our pleasure to participate complex PCI this year. Let me introduce my team. In most the right side, she is the third-year intervention fellow. In right side, he's Dr. Lee, Yong-Jun Lee, and the interventional cardiology staff in our hospital. Actually, he has been my student very long time, for 10 years. I really cherish him in my mind. And now he become the representative of one of the representative of my hospital. And actually, he did a very hard training during the last 5 or 6 years. I'd like to brag about my colleague. Actually, he did achieve a lot of the achievement in the academic aspect. Last year, he did two big major journals. One is JAMA, and the other is the BMJ. This year, Circulation and the European Heart Journal. Most important one, this year, he applied for the Young Interventional Award in TCT-AP next year. So please, see my colleague, and okay, Dr. Lee.
All right. You're proud of me, right? All right.
Thank you,
Of
Professor.
course.
Great.
Thank you, Professor. So I'm going to briefly present our patient. So our patient is a 68-year-old male who came to our hospital due to the exertional chest pain, which lasted for several months. He already had a history of stroke, and we already put in a stent last summer. Next slide, please. And as if the important aspect of this patient is that he had a history of CKD stage 4. His GFR was about 35. Well, on his echo, we did the echo recently. On echo, we could see the newly developed regional wall motion abnormality at the territory of the LAD and RCA. Next slide, please. And this is nothing to do. Next slide, please. So this is the angio. The left one is the initial angio we done it the last summer. You can see the significant lesion at the proximal RCA, and you can see the middle angiography. We have put in the stent already. However, he came to our hospital due to the chest pain, which started recently, and you can see the new lesions at the proximal site of the stent site. So in the last angio, we have put it another stent at the proximal RCA, that's the final angio. However, we have to remember that he already had the regional wall motion abnormality, not only at the RCA, but LAD. Next slide, please. And this is the LAD, the left coronary arteries. The circumflex seems okay, but you can see for the LAD, you can see the very diffuse long lesion at the LAD, starting from the mid to the distal LAD. Next slide, please. So this is the presentation.
Okay, my plan is to fix the LAD. When we use the contrast dye enoughly, and most of the intervention is to achieve the very excellent result. But I'd like to fix this patient with the image guide PCI with a minimal contrast. Ideally, so zero contrast and fix it. That is our plan. Any comment or question about these cases?
Comment on that one. LAD region. Would you show us angiogram, Dr. Hong? We cannot see that.
We do not check it in right time. you know, this is a CKD stage 4 patient. The procedure, I think, is a preservation of renal function is more important than the procedure itself.
So meaning is
So
you
we
didn't check the coronary angiogram so far, right?
Yes. So
All right.
actually, in the 1 month ago, we
All
only
right.
checked in the left coronary, only 3 checked, the 3 view, and that's it.
Would you
And
show us
now
a,
we start.
would you show us a
Yes.
coronary angiogram 3 months before? All right, previous one.
1 month ago, okay.
1 month ago, right? You got no idea, right?
Yes. 마지막, this is a 1 month ago, the angiogram in the left. This is a target.
Mid LAD,
Yes.
long lesion.
Yes.
Show us aerial view. So you're going to see the diagonal branches, ostial part, how much compromise, something like that.
I will.
Could you show us that
run.
one? Okay.
Yes.
All right. Central one. Good, perfect.
So are you intending
No,
to
so
just,
only three view, 3 projection.
are you planning to put in several wires to create a skeleton map of the vessel and then use IVUS?
Of course. Of course.
Diagonal branch, you know, ostial part is looks normal, and procedure-wise, I think we don't need a wire protection for diagonal branches. Just you don't want to use contrast, right? Just stand middle portion, maybe 33 and 38 to 5, quite enough. 2 5, and they can make a little bit high pressure. Something
You could
like
use IVUS to size it, right? You can use IVUS
Yes.
to size it.
Yes, I will determine the what extent, what size of it by the IVUS.
I think the one challenge will be that if you need to stent all the way back to the ostium, you know, I think the left main is very short or probably non-existent, so the stent positioning there will be tricky without contrast, but potentially can be done.
Right. So anyhow, the
Are you going to do IVUS?
most important principle, minimize the contrast. And we will try to fix it, the mid-LAD portion. That is our plan. Okay? So please show us the fluoroscopic image first. 백생 보여주세요. 가이딩 건 거. Okay. And this is the guiding engage. It's a XV sidewall, 7 French. When you look at the guide engagement and the azimuth LAD, how do we confirm it is a really correct position or not? When you look at the carefully tip of the caster, finally sudden duck, and it means that from the experience, okay, this is the correctly position this time.
All right.
And then I'm sure, but we have to confirm that. Then next. And then carefully next. Advance it. Okay, then next. And try to the wire and in the distally. Next. Next, next, next. Okay, then 아니 before 그전 아니야 앞에 아니 forward. IVUS. We confirm that the position of the wire with the IVUS. Wire is really positioned in the true lumen of LAD. Confirm it. Okay, that's it. And next. Next. Then wiring without the still, no contrast. Try to the wiring based on my tactile sensation. And then carefully advance based on a reference view which was taken in the 1 month ago. Then next. And then check it, the position of a wire in the diagonal branch with confirmed by the IVUS and confirm it. Okay, next. And this is a septal branch. Carefully, cautiously. Okay, next. Next. And confirm it, the wire position was IVUS. Now I'm confirmed that whole wire position in a true lumen. This is the basic setting for this patient. Okay, next. And then finally, the most important thing is that do not move the table. Actually, 1 month ago, the projection, RAO projection is RAO 36 and the cranial 27 is the same one in this time. And then finally, I do the IBIS. 프로로 계속 런 해주십시오. Looking at the 프로로 run. Okay, 괜찮은 거. Looking at the simultaneous and the IBIS and the transducer position is the marker for the distal stent. Next. This is that one. Next.
Great.
And the proximal transducer, that is the proximal target for the stent. So we measure the whole length. So therefore, stent length is about 38. Okay. Please show us the final last IBIS image and the LAD.
Okay.
천천히. Run.
3O.
Okay, this is a distal reference. Vessel size around the 3O, and the plaque is here.
3O to
3O.
Between the two fibers, right?
In here about the lumen area is around the 2.1, and now above the diagonal branch. Actually, this is the vessel size discrepancy, and there is another narrowing. This is the area is 2.6. Vessel size was more than 3.5. So based on this finding, so far I did not use any contrast so far. But something happened, I will use the contrast. But depends on some hemodynamic situation, I will do that. But so far, no contrast. And the plan is predilation 2.5 and 2.75 and around the 38 onyx stent deployed. And then what is the more next step? Region was really well covered or not, and the other we need more stent and the others. That is my plan.
How did the proximal LAD look all the way back to the ostium? Relatively disease-free?
If you want to know that actually after the end of this procedure, I will check it. Okay. Proximal LAD and the left main. I think the size of the proximal LAD and the left main is small. In angiographic appearance, I agree. And we will check it by the IBIS.
Okay.
So
2.5.
So predilation, and you just do stent?
Yes.
All right.
Simple. Actually, as I said, most of the intervention is to do this kind of the relatively simple lesion with the contrast, maybe 100 millimeters contrast. Everybody, most of the intervention is to fix it. However, this patient is some very specific for the CKD. So I'd like to delay to start the hemodialysis in this patient. Therefore, the access site for this patient is I select the femoral rather than the radial to avoid any injury in the radial artery. 이거 맞지? 이거 LAD가 조금 깊게 들어간 것 같아서. 이거 맞아? LAD 맞아?
이게
맞아? 세탈이지?
This is LAD. 응? This is LAD.
LAD 맞아?
So for the zero contrast PCI, we usually use to the patient who is allergic to contrast. But for the CKD4 end-stage chronic kidney disease patient, we usually don't care about that. And the worst situation will be send the patient to accept hemodialysis. Sometimes temporarily, only one-time hemodialysis will help the patient. So in this case, is anatomically not that difficult. But usually for CKD, end-stage CKD patient, the anatomy is very complex, so zero contrast will be very difficult.
I feel some resistance to advance the balloon, so I will change the balloon.
It might be wire wrap.
Yeah.
Yes.
So
your diag wire is sort
if you right.
Okay, thank you.
What's the size of the guiding catheter? 7 or 6?
7.
Well, actually, I'm also a big fan of zero contrast PCI. But I think zero contrast is only a gimmick. I mean, we aim at very minimal contrast use. So we try to avoid injection of contrast at any time, except when you feel that there's some complication that happens. And also except at the end of procedure, you want to prove that the angiogram is good for medical legal purpose. But I think for me, I seldom use this kind of wire skeleton because I think from IVUS, the operator should have the angiogram in our mindset, so we know exactly where the branches are. And the use of wire skeleton, of course, can make this mental picture clearer. But the downside would be there are so many wires. There's some wire tangling. So sometimes it makes the procedure even more complicated.
8.
I agree. So the ideally zero contrast. So we must do it. No, I don't think so. It depends on the clinical situation during the procedure. Inflate. Okay.
Is this 2.5 balloon, 2.5?
Yes,
All right.
2.5.
If I remember correctly, and there was a paper that showed the
right.
instance of CIA in the patient with the eGFR around 30. It's just significant CIA in just about 5% of the patients.
All right. All right. I think if I were you, Dr. Hong, anyways, we made a previous angiogram here, and so practical point of view, diagonal branch would be good even after the main branch stent crossover. So we don't need a diagonal wire and septal wire remove. Just a single wire and direct stent would be more easier to right. You can imagine, right, based on the last angiogram, right?
Yeah, in that approach, you can finish with just a 50 milliliter of the contrast.
So I think Professor Wong too much worry about in the contrast isn't used because in a small amount contrast also is fine.
Angio,
and then much more simple procedure. And then before the angiography, we can have some hydration with the prophylactic.
The purpose of the septal wire, actually, it does not need it, but the main purpose is not for the side branch protection, is for some marker.
I think it's perfect, right? Perfect position.
어때? 조금만 나올까?
A little further.
Okay.
0.5 millimeter.
가자.
Right, great.
노민 얼마네? This is a 2.75.
10,
2.75.
nominal.
11, 12 nominal.
Ooh,
Balloon.
big.
A little bit
Okay,
too proximal.
let's see
big, huh?
what's the
A little
the
bit too
IBS
proximal.
image, and based on the IBS image, I will do the more dilation, particularly in the proximal to the diagonal branch. 잡아, 꽉 잡아. 와야 나오면 안 돼.
Great.
I'd like to insist zero contrast PCI. No. That is some ideal goal. Anyhow, try to achieve such kind of ideal goal. Practical purpose, something happen, why not? We have to use it.
Actually, yes. I think even for more complex case, we also aim at minimal contrast because actually you will achieve more complete revascularization if you minimize the contrast. You after 2 hours, you only use 10 Cs of contrast, then you're very happy to continue with the procedure. Versus if after 2-hour procedure, you have already used 300 mil of contrast, and you want to stop and stage to another side.
I think the stent positioning is critical in this case, so maybe you should have used the contrast before dilating the stent. Actually, it might be a little bit looks proximal.
Are you going to do IBS?
Yes, good
All right,
comment.
great,
Let's
great.
so confirm by the IBS.
Okay, great.
What happened? Confirm that.
Good. Stent silhouette is perfect. I think I do.
꽉 잡아줘. 되게 뻑뻑하네. Because so far I do not use the contrast or what happened in the side branch vessel or occlusion or not. Practical point of view, I don't know, but the hemodynamic appearance, there is no ECG change.
Great.
There is no. So okay, please show us. 아직 하지 마. IBS on a screening.
Okay, IBS. Great. Digital?
Yes.
301.
Very good digital landing.
Perfect. Perfect. Digital landing. Send is good. Fully covered. All right. More than two.
Based on the IBS finding, where is some specific point we did more procedure, particularly in the proximal vessel. Actually, proximal vessel is more than a 3.5. So, but I did that 3.27. So. What do you think in the position of the stent?
Perfect. Perfect.
Okay,
like
thank
it.
you. So
Right.
we confirm is anyhow. This is the procedure itself is by experience itself, and then and something
Alright.
wrong from the IBS finding, fix it more.
We need a little bit high pressure inflation, 2.75 something, and
Where?
mid part on the expanded
Okay.
area. Maybe here, those vessel size is big enough and still relatively small stent diameters.
Especially in the proximal, right? Correct.
All right. Proximal is okay. Here, so we can dilate it a little bit further. Very proximal is perfect, right? Here. Plaque burden is not pretty much. Septal.
So you landed just beyond the septal then. Looks
So. Area.
stent
That's
area.
quite enough.
So 어느 게 septal이지? 이게
Proximal?
septal인가?
Proximal part?
This is it.
응?
This is 이거 septal입니다.
So it's time now. Septal wire does not need it. You use it for some landmark. Remove it. 3-0 non-compliance balloon. 3-5. 3-5.
3초.
15.
Okay. Then, are you gonna do high pressure?
Yes.
High pressure flash. All right.
As you recommended, I will do that.
What size balloon
What
are you
size?
going to take?
275.
For the saving of money, I will start at 3.5. Or it looks like a little bit bigger.
3.5 might be
But,
too big, right?
Okay. That is some reasonable way of thinking. I agree.
So, what size? What size?
It's 3.5.
Still 3.5.
35.
Is it bigger?
Yeah, I think so.
Okay, let's
All
see.
right. The meaning is, you have already effective standing areas more than 5.86 millimeter scale. So you may know that the cutoff value is in any regulating stage 5.5 quite enough. And so I think if we use a 2.75 the NC balloon, we can make a 3.2 something. That is my procedure concern. That's a little bit different concept.
Before the high pressure balloon dilation, I will remove the diagonal branch wire. 이거 아니야? 맞지?
네, 맞습니다.
노미널이 얼마지?
I mean, the problem with removing the wire is that if something happens to the diag now, it's going to be hard to retrieve it.
Good comment.
So
Right, agree. 이거 얼마지? 노미널이 얼마야?
12입니다.
I would have been inclined to leave,
Six.
leave it before, take your final picture and then remove the diagonal wire.
발론.
6
Agree.
6 atmosphere,
Yes.
relatively
Go.
lower pressure with a big balloon. Good.
I don't know. My preference is to take a smaller balloon and go very high pressure. I like 26, 28 kind of atmosphere pressures.
Okay, go ahead.
12 nominal.
발론. The high pressure balloon is needed, but and what is the result? Even though I did not up to more than a 20, but the lumen area is bigger enough. Why do need a more bigger high pressure? So how much pressure is always based on the IBS finding. That is my way of thinking. How?
Perfect.
잘 빼자. 스타킹이 됐어.
Some difficulties.
Balloon is
All right.
trapped by wire, so I feel some very strong resistance.
Some
Maybe I need a rewire.
anchoring, rewiring. Good. Push in. Okay. Difficult.
Yes.
Okay. Dr. Hong is really, conceptual nice presentation, zero contrast angioplasty, those. Anyway, we don't want to see final result, right? Just service.
Actually, I would love to see one final picture.
All right, service finding is quite enough, right? And
If you want to do that, okay, for a special service from the SCA, I will do that.
all right.
Very minimal.
Anyway, once more, thank you for.
What view? Because only one view is allowed for this patient. What view?
All right.
This
This
view.
view
Yeah.
or areocranial? What view?
This view.
This view.
All right,
Okay.
same view.
Okay, let's check it.
1 cc.
Okay.
You can
should inject
dilute
only one cc.
the contrast.
1 cc. No more than that. Picture.
Yes. Actually, there is some air in the guiding caster, so I remove the air. Okay, picture. What do you think?
Perfect. Wow, great.
Thank you.
Very nice.
All right, great cases. Dr. Hong, really thank you again for joining us. We have a really, quite good concept in terms of particular those patients. All right, see you next TCTP meeting. Those right. So
So we're now ready for our
Doctor,
feature.
just one. I was standing here. Dr. Ahn, can you hear me? Jung-Min Ahn. Okay.
Right, so we're now ready for our featured lecture from Dr. S.J. Park, left main and multivessel disease, updated concepts and treatment. Dr. Park.
Thank you. I briefly review about the main and multivessel updated treatment concept. Okay. At first, the global revascularization guideline for left main disease. If you look at the 2018 ESS guideline, look at this. PCI concern, intermediate syntax score 2A, high syntax score is don't touch about 3B. However, data since then, 2018, many data, syntax 10 years, Excel 5, pre-combat 10 years, Noble 5 years, 2019, 2003, combined meta-analysis about the syntax pre-combat, Noble Excel study clearly demonstrate hard endpoint all deaths, no different error or PCR versus bypass surgery. And so 2024 ESS guideline changed like this. And so they're more descriptive, separate with the main with multivessel disease, and still they measure the syntax score, low complexity, intermediate complexity, and high surgical risk concern. And so if you look at the high syntax score in the main disease, caused by, look at this, low syntax scores mainly included, remain isolated single vessel, two vessel. However, high syntax scores included concomitant to three vessel disease. And so they separate in terms of main disease and main with multi-vessel disease. Anyway, it's a big changes. Still, in general, bypass surgery is class 1A, low complexity syntax score, intermediate 1A, 2A. It's great, almost same. However, big changes. This group would be high syntax score, high surgical group PCI may be considered as a medical treatment 2B indication. If you compare the 2018, big changes from the 3B and 2B, and so 2024 main PCI class 1A, according to the degree of complexity 2A, 2B. If you look at the 2021 HHH guidelines, almost the same main disease. They separate with a high anatomic complexity. They're suitable for candidate for bypass surgery. They send the patient to the surgery. So, meaning high anatomic complexity, suitability, what does it mean? How do we define anatomic complexity and surgical suitability? In the HCH guideline, they don't believe too much about the usefulness of a syntax score to be in the treatment of decision making is less clear because of inter-observer variability and its calculation in the absence of clinical variables. And so just imagine that the high anatomic complexity, you've seen the, so two cases. Dr. Buck, Dr. Ahn, main multivessel, complex main calcification, bifurcation, there is a anatomically high, suitable candidate for bypass surgery. They define is a 1.5 millimeter small vessel diameter, however, acceptable to anastomosis is okay. Anatomy, suitable for PCI, more than 80%, reference vessel diameter is more than 2.25. So, low anatomic complexity, look at this. Bypass surgery in case of main disease, PCI class 2A. So ACCH guideline 2A for low anatomic complexity. So main PCI as compared with the bypass surgery, the global guideline actually do not take into account operator experience and the technical consideration. There are significant differences in the way main disease interpreted. Look at this, main disease, big vessel, proximal lesion, short lesion length is really good target for angioplasty. And so recently, we've changed in terms of a contemporary PCI. We define that one new advancement in the current PCI can be considered as contemporary PCI, physiology, and imaging supported. All the cases you've seen that I was FFR guided decision making and image guided supported PCI procedure. Look at this case. Ostial shaft disease, no more surgery anymore. Main ostial disease, just stand it. It took 5 minutes, and 2 years later, absolutely, no change at all. And so, bifurcation lesion, 1 stent, 2 stent, this is a very classic one. Main bifurcation, small diminutive, less than 2.5 diameter. Just the first cases, actually big circumflex, however, not too much disease over there. 1 stent cross, both will be okay. True bifurcation for larger circumflex. So this is angiographically bifurcation. We cannot differentiate what's different between the two cases. However, according to the circumflex disease status, is the first one absolutely normal circumflex ostium. We're going to do the stent crossover. Second case is there are lots of diseases, circumflex ostium. We have two stent cross like this. Angiographically almost perfect. Look at this. Negative FFR, positive FFR, LAD concern, IVES guided. No disease, not significant disease or circumflex ostium. We did just a stent crossover. Look at this, circumflex ostium, a little bit compromised. However, it's not a big deal for the clinical outcome, long-term outcome. 2 stent technique, true bifurcation disease. We have to confirm significant stenosis of a circumflex ostium, LAD ostium, and then for particular this true bifurcation, we're going to do the mini crushing. First the circumflex and second LAD. Just, you've seen the second case, Dr. Ahn's one, sequential high pressure, final kissing bone inflation, almost perfect. The same result, like, any bifurcation PCI concern. LAD 8.8 and circumflex 5.1 is we're going to, explain the later. Minimal stent area is 8 millimeters square, is quite enough for LAD. Right, that's one. This is a new data, 5 years long-term, TLR rate less than 5 minutes, 5%. The cutoff value is 6, 8, 12 millimeters square is getting bigger. So previous is angiographic follow-up data. So current our practice, ostial shaft we place the stent in every case, 100%. Isolated remnant bifurcation suitable for PCI. Anatomically, PCI is preferred for almost all cases. Main with multivessel suitable for PCI. PCI is preferred. Main disease, extensive coronary artery disease, and low ejection. It is a very practical point of view. Less than 40%, not suitable anatomy for PCI. CABS is preferred. Those patients with multiple comorbidity, we have to consider PCI. And so, in practical point of view, in our reality, more than 80% of main disease, we perform contemporary PCI. So we just started. You will see in the two cases, Fahim main coronary artery angiography more than 50% diameter stenosis, eligible for PCI, FFR guided, angio guided. We're gonna start soon. So main disease anyway is not surgical disease anymore. Okay, move on to multi-vessel PCI. 2018 ESS guideline. Look at this, 3A. A low syntax score with diabetics, don't touch by stent process. That is a message from the 2018. However, they've changed a lot. It's multi-vessel. They separate with the multi-vessel with the diabetic, 3-vessel without diabetics, and just you've seen the 3A guideline changed a lot. In bypass surgery, multi-vessel diabetics, class 1A. Look at this. Even diabetic patient, high surgical risk PCI would be 2A, quite improved, the guideline class. And 3-vessel and without diabetes, the PCI would be 1A, almost 1A. So 1A and ESS guideline multi-vessel PCI 2A, depending on complexities, no more class 3. ACC guidelines, multi-vessel, they separate with the patient who had a low ejection fraction, less than 50%, data based on the CAST trial, data based on the STITCH trial, and very low ejection fraction, less than 35%, bypass surgery is good. However, ejection fraction is the only index that indicates the surgery as a better option. However, normal ejection fraction, even multi-vessel, 3-vessel, bypass surgery, PCI, any revascularization, guideline is 2B. If you look at the in detail concern, look at that. Normal ejection fraction, even 3-vessel disease, bypass surgery, 2B. Usefulness of PCI, 2B. Proximal LAD, useful 2-vessel disease, any, no survival benefit, 2B. 1 or 2 stent non-proximal, you want to touch with them, there is no benefit at all. There is 3. So multi-vessel revascularization, normal ejection fraction is still 2B. Lesson from the ischemia study, you know that moderate, severe, multi-vessel disease separate with the invasive, conservative, clinical outcome, hard endpoint, death, myocardial infarction, no difference at all deaths extended 7 years, no difference at all, clear insight, no survival benefit, ischemic event benefit, but invasive surgery, invasive strategy, optimal medical treatment is quite enough, even in the multi-vessel severity region. So only survival benefit, diabetic, based on the current data, diabetic 3-vessel, multi-vessel, low ejection fraction, less than 35%, poor candidate for bypass surgery, PCI may be considered. There will be changes, right? Multi-vessel with a normal ejection fraction, and revascularization 2B current. My practice, all ischemic lesion, favorable anatomy for PCI, more than 2 big vessel, long lesion, less than 50, however, more than that anyway, PCI favor. Ejection fraction, low ejection, less than 40, diabetic, 3-vessel, CABG favor. And so, majority of multi-vessel disease, 1 or 2 major vessel PCI with optimal medical therapy would be enough. Look at this, current data, current guideline based on the old data, very to freedom study, almost 10 years ago, 20 years ago, syntax study, limited interpretation, all the study used all the DS, Texas, and lack of data for a diabetic patient, just only freedom study, lack of concept of physiology and imaging supported PCI. So, contemporary PCI, FFR guided, IBS guided procedure, right? This is typical examples. Contemporary PCI, angiographically 3-vessel disease, diffuse LAD, proximal RCA diffuse disease, circumflex distal disease. However, RCA FFR negative, circumflex distal small vessel disease, we want to focus on the LAD region itself, diffuse long region. By ARMS findings, look at this, basically very diffuse disease. However, we're going to do stented proximal part of two drug stent and distal FFR anyway is 0.91. Diffuse disease, depending on Ives finding, proximal corrections, sometimes it is quite enough. So look at that. Despite being 3 vessel disease, only LAD stent with optimal medical treatment and effectively simplified treatment was performed through the contemporary PCI, the physiology, and imaging guided PCI. So look at this. We have no data yet. Contemporary PCI, totally different concept. I told you, versus bypass surgery for multi-vessel with ischemic cardiomyopathy, less than 35% ejection fraction, stitch, right? 3 trial. And contemporary PCI versus CABG multi-vessel with the diabetics, we have no data. For the above 2 topics, we need a randomized study. And so we just started the defined DM study, diabetic, 3 vessel disease, amenable revascularization by PCI or bypass surgery. We do contemporary PCI and surgery. So we want to compare with the PCI and surgery. So I would expect in the 5 years, 10 years later, contemporary PCI combined with optimal medical therapy will become a standard treatment for any multi-vessel disease in the future. Thank you. That's my
That's an amazing talk, Dr. Park. Can I ask a quick question? What is your approach for the highly calcified circumflex, where there's nodular calcium and you're just not going to be able to get good expansion there? Do you just DCP those when you do left main PCI, or do you still put a stent and accept a suboptimal area?
You mean calcified circumflex hosting, right?
Very calcified nodular calcium at the circumflex. That's where most of the restenosis.
We've discussed before. Anyway, we try the NC balloon first. In any case, right. I don't believe it. If wire, and balloon cannot pass, and we're going to think about the road ablation for, modifies the plaque itself. And depending on the circumflex size-wise, it's not a big, big one. I just leave it alone. I don't want to touch with it.
I agree with you. My own approach is to actually not do it and just leave it or DCB it, because they always come back with restenosis. And I think we have to accept that there's some spots in the coronary tree where putting in a stent is just often not productive. So.
Okay. Anyways, Dr. Ahn, any comment on that?
No, I think just only one comment or question to you that when you previously, the presentation is that you think about in the ischemic burden in the Crohn's stable disease or ischemic cardiomyopathy, how can usually you identify the ischemic burden to touch or not touch the coronary arteries? Because sometimes it's very difficult in the multi-vessel disease patient.
All right. The previous stitch trial, actually, they didn't concern about the presence of ischemia. The ejection fraction, less than 35%, mean ejection fraction 28%, something like that. However, they compare with just medical treatment and bypass surgery. At the beginning, they didn't find any difference in terms of. So we can make another sub-study concern, define the viability of a myocardium. However, low ejection fraction, less than 35%, actually we have to compare revascularization and medical treatment, and we replace the bypass surgery with the PCI, contemporary PCI. That is the recent stitch, study.
I mean, the issue with ischemic cardiomyopathy, the complexity is, of course, after revived BCIS, we don't know whether revascularization with PCI makes a difference. Of course, it was not as optimal. It was not the optimal PCI that you've defined. So I think it's still an open question that whether ischemic cardiomyopathy, often coronary disease is bystander disease. Somebody has a cardiomyopathy, EF 20%, 3-vessel disease, but the arteries are open, there's STIMI3 flow. I'm not sure all of that coronary disease is the cause of the low ejection fraction. And what happens is we do PCI, we also put them on Entresto and all the other 4 drugs, and the EF gets better, and we don't know which did it. So I think a lot of these cases are probably just bystander coronary disease that can be treated medically.
Exactly. According to, all right, Stitch study, they compare with the bypass surgery and medical treatment. 5 years follow-up data, no difference at all. Any, heart impact. However, 10 years of follow-up data has a very small difference in heart impact concern. And so the reason why we have to focus on the, anyway, revascularization would be a little bit better for that. So at the next stages, we want to replace with the contemporary PCI with bypass surgery. That is this way. All right, this is really, first session is exciting, the main cases, and from the Dr. Hong, no contrast, angioplasty is required. And interesting, and so lots of discussion. Thank you for all the.
Thank you. Thank you.
We're going to close this session.
Thank you.